So again, welcome. My name is Erin Collins. I serve as the program director for the Peaceful Presence Project here in Bend, Oregon. I've had the pleasure to meet many of you. If we haven't had the chance to meet, welcome. I'm joined this evening by Elizabeth Johnson, my co-director who serves as the executive director of the Peaceful Presence Project, Angelique Loscar, who is one of our board members, and Laura Munn, who is a Peaceful Presence trained end-of-life doula in the Columbia River Gorge, living on the Washington side. And we're really grateful for the opportunity to share our experiences with you around medical aid in dying and voluntary stopping of eating and drinking. So what we're really here to talk about this evening is not so much an in-depth exploration of the two processes of medical aid in dying and voluntary stopping of eating and drinking, although we will give a pretty good overview of those two processes. But really our focus tonight is, as end-of-life doulas, how we are able to be supportive for folks who are choosing either one of these end-of-life choices. So you'll get a good overview of how doulas can be supportive, whether you are an end-of-life doula and wondering about your role in the process, or you're someone who might you might choose one of these options one day and wonder how a doula can support you. That will really be the focus of our presentation this evening. If you haven't had the chance to interact with the Peaceful Presence Project before, I just wanted to share briefly that we are a nonprofit organization based in Bend, Oregon. Our mission is to reimagine and transform the way that communities talk about, plan for, and experience serious illness and the end of life. We really envision a culture in which every community member receives compassionate and equitable support through the end of life. A big portion of what we do is community education and end-of-life doula training, and so this is one of the many offerings we have throughout the year. If you'd like to, if you're not already subscribed to our newsletter, you can find that on our website, on our contact page, a way to subscribe. So starting with medical aid in dying, I wanted to share this definition of what medical aid in dying is. And this is up to date as of 2021. This is the most current definition that was really worked on comprehensively with medical professionals, legal professionals, to truly capture the essence that medical aid in dying refers to a legal practice in which a clinician cares for a terminally ill patient who may be considering and potentially follows through with hastening their imminent death through the use of medications prescribed for that purpose. It is not suicide. It is not assisted suicide. And the clinicians who have been involved with the process over years really wanted to capture the idea that medical aid in dying is a process of a physician or a practitioner caring for a patient. It's not just a physician writing a prescription to end someone's life. And so this newer definition is now in a database called Up to Date, which is where a lot of clinicians go to define different medical procedures. And so it's really exciting that this is now the most current definition, showing that clinicians care for people who are considering this as an option. Medical aid in dying is currently legal in 11 states. And the states that are listed here are those states. Oregon was the first state to adopt the law in 1997. And the most recent state to adopt the law was New Mexico in 2021. The two starred states, which are Oregon and Vermont, are the two states where there is not a residency requirement anymore. So a physician in those states can write a prescription for someone who is not a resident of those states. Within these 11 states, there are a number of variations. Some of these include who can prescribe the medication, meaning does it have to be a physician? Can it be a physician's assistant or a nurse practitioner? Variations in how many clinicians are needed. Some states have just a requirement for one. For some, it's two or even more. There are variations in who is eligible, meaning the kind of diagnosis and prognosis. There are differences in how long one has to wait before receiving the medication. So that means in some states the request is made and there is a waiting period of 48 hours up to 20 days before someone can actually receive the prescription, the prescribed medication. In some states, there are waivers for that waiting period if someone is more imminently dying and it's seen that they would not make it through 20 days. Some states will allow a waiver to make the process quicker so that they can use the law. Different states have different clinicians' ability to conscientiously object. So whether a clinician can say, I will not participate, and that often happens with hospices. There are differences in how many capacity assessments are needed, and a capacity assessment is the assessment that two physicians make whether someone has the cognitive ability to make this choice, to understand what will happen if they take the medication, and who can do a mental health assessment. In some cases, there is a referral for a mental health assessment to make sure if someone, again, has the legal capacity and the ability to make this. And then, like I mentioned, the residency requirement, which in Oregon and Vermont have recently, in the past year, eliminated that residency requirement. Who can use medical aid in dying in pretty much every state is about the same with this, and that is that it needs to be an adult who is someone aged 18 or older. The person needs to be terminally ill with a prognosis of 6 months or less to live, and that typically means that they would qualify for hospice. It's generally recommended that someone utilizes hospice care as well to try and make them as comfortable as possible. The person needs to be mentally capable of making their own healthcare decisions. And they also need to be able to self-ingest the medication. There are assistance options. And that just means that self-ingesting the medication doesn't always mean that they have to orally be able to swallow the medication. For someone who has a disease process that won't allow them to swallow, they may have a neurological condition. There are other routes that can be used, whether that may be through a gastronomy tube or a G tube. If the person is able to activate a plunger that would allow the medication to go in. There is rectal administration that also uses a plunger, and if the person can administer with that plunger. There are a lot of creative ways that across the country, clinicians and physical therapists and occupational therapists are helping people to be able to use this law to avoid suffering, even if they aren't able to orally ingest. If they can't actually physically push a plunger, there are also contraptions that have been devised. So we really are finding a lot more accessibility and creating options for anyone who may want to use this law. I'm going to hand it over to Angelique to go through a really excellent resource for both doulas and family members. And I'm going to pin you, Angelique.
Okay. So for anyone who's interested in either learning more about medical aid in dying or perhaps supporting a client through that process, this website is an absolutely phenomenal resource. So it's the American Clinicians Academy on Medical Aid in Dying, and the website address is up there. I'll just walk through a few of the resources that I think are especially helpful for this group. One of them is an end-of-life doula training. So very specific to doulas. It's 2 45-minute videos, which are really valuable. They have an incredible amount of information on how doulas can support clients through the Maid process. And if you watch both of those videos and then you take a little quiz, you're able to be, first of all, you get a certificate of completion, and then you're able to be included in their referral system. So that's another resource that they offer to the community is referrals for anyone who lives in a state in which medical aid in dying is legal. People can contact the academy, provide us some information, and they can get a referral to physicians, nurses, maybe even pharmacists, because sometimes there's difficulty finding pharmacists who will compound the medication, and of course, end of life doulas. For those of you who decide to move forward and support clients through the medical aid in dying process, your best friend is going to be their clinician's hotline. And that's a hotline that's staffed 24/7 with people who have tremendous amount of experience with medical aid in dying. I think that the cumulative number of patients that they've worked with is it's certainly in the hundreds. And it's a really incredible, great group of people. So you can call them with just a general question about the process if you're working with a client, or if you are actually there with a client in the middle of the process and something seems to be going wrong, they're just an incredible resource for you. And then the last one I wanted to mention is, and there are some other ones up here as well. You can play around with the website, but they have a listserv, which is a really wonderful source of all kinds of different information. And some of the discussions that go on there are just so interesting. So they range from the legal questions, that are state-based. Ethical questions are often brought up on that listserv. And then some of them are just incredibly practical. Like Erin was talking about the different ingestion methods and how people kind of work with patients where they are to be able to allow them to ingest within the guidelines of the law. It could be how to dispose of these very potent medications that aren't used and things like that. So we can go to the next slide. All right. I wanted to touch on pharmacology just briefly, because the Academy, in addition to offering all those other resources, they also offer practice guidelines and protocols, and the pharmacology or the medication used is one of them. It's all very data-driven, and I'll talk about that in a second. We have a very large database of over 1,000, almost 1,100 patients right now, that clinicians, enter the data, and then we do some analysis on that. And, and we look for what are the most effective medications and a lot of other things I'm happy to talk about later if people have questions. But just talking about the medications here. So the drug that's being used has evolved over time since Oregon first approved the death with dignity law or legalized death with dignity in 1997. Way back then, the medication that was used was called Seconal, and some of you might be familiar with that. But for a number of different reasons that I won't get into here right now, it's kind of moved, it's evolved over the years. And since about 2020, DDMAPH is what we call the medication combination that's used. And this is a combination of 5 different medications with 2 primary objectives. The first is unconsciousness, so put the patient to sleep. And then the second is to stop the heart. And the unconsciousness, diazepam, morphine, and phenobarbital work toward that goal. And then digoxin and amitriptyline are the medications that will stop the heart. So DDMAPH has been in use since about 2020. And like I said, it's compounded by pharmacies in the states where medical aid in dying is legal. And we arrived at this by looking at the data and understanding, what seems to be working the fastest on time to sleep and time to death. There are other considerations as well, and Erin may talk to some of these. So cost is certainly one of them. But also, this has an incredibly bitter taste. They're always looking for new ways to make that a little bit easier for the patient. And then let's go ahead and go to the next slide because I want to show you a little piece of data here. So this is based on our database of almost 1,100 patients. And what we know is that if folks follow the protocols of the Academy, then you can be reasonably sure that the death will occur within about 2 hours, which is a really comforting statistic to have for the patients and their families when you're talking through this with them. In fact, the median time to death is 45 minutes. And as you can see, about 79% of the deaths occur in under 2 hours. And then when you look at under 5 hours, that number goes up to about 94%, which I think is pretty fantastic. We also look at minutes to unconsciousness because that gives the patients and their families a certain degree of comfort to know that this isn't going to be elongated process in which people are kind of aware of what's going on. And median time to unconsciousness is about 5 minutes. And again, almost everybody is unconscious within about 10 minutes. So I just wanted to share those two statistics, and if anybody has questions on them, please let me know. I am a volunteer with the Academy and do data analysis for them. I think, Erin, all yours.
Thank you, Angelique. Let me just get you unpinned. So I just wanted to spend a couple of minutes sharing a story, and I'll first start with just a couple of details referring back to what Angelique said about my experience with helping this family to administer the medication, and then I'll share the story, which is more of a narrative. This family, so Angelique mentioned that the medications can be bitter. There is a recommendation that the medication is mixed with a small amount of apple juice to take away a bit of the bitterness. There's also the current practice is kind of a sorbet sandwich, so to speak. And so we have a couple of bites of sorbet prior to administration of the medication. It numbs the mouth and it puts a sweet flavor in the mouth. Then the patient can ingest the medication. This is for folks who are ingesting orally. They can then ingest the medication and take a couple of scoops or a couple of spoonfuls of sorbet after, again, to take away the bitterness and to add some flavor and to continue to keep the mouth cool. There are reports that at sometimes the medication can burn, and so that sorbet helps to alleviate that. And I just wanted to share what was really sweet about the family I served was that they had a sorbet buffet. Their mom really just, she loved ice cream, and I had been very specific that we wanted it to be sorbet. And so they went and they just got all the kinds they could get. And then they just kind of put it out and said, we're going to have whatever flavor she wants at the time. And the flavor of choice ended up being peach. And so it was very sweet, not literally very sweet, but a very sweet aspect of the process. I had the great honor a couple of weeks ago for World Hospice and Palliative Care Day. There was a large international conference, and they had the Palliative Story Exchange, and I was invited to share this story. And I thought rather than me just relaying information to you, I thought it would be nice to share this story. So I hope you all will enjoy. I became a nurse because of hospice. I was 24 and watched hospice nurses care for my grandmother with dignity-conserving respect and tenderness. I knew this was how I wanted to show up in the world. I spent 13 years in oncology and hospice nursing. I led with what my teacher, Roshi Joan Halifax, calls a strong back and a soft, open heart, as I administered medications and planned for care, even as the time I had available to each patient dwindled. When I came to observe in 2018 that many of my patients came to hospice afraid of death, in denial of it, and largely unprepared for it, I felt like there had to be a better way to ease the suffering that this all created. There had to be a way to get the public and individuals talking about and planning for illness and death before it was a crisis. I had to figure out how to ease the suffering I was witnessing. So I became an end-of-life doula, embedded in my community. I co-founded a community-based organization. I rolled up my sleeves and I got to work. Many times since I made that switch, I've been unsure of my decision. But just as many times, I have been reassured of it. February of this year was an interaction that was one of the most impactful reminders. I live in Central Oregon, where winter can be quite severe. Our service area is 10,000 square miles of vast open space. Farms, ranches, small towns, and the unceded lands of the Confederated Tribes of the Warm Springs, Wasco, and Paiute nations. The eastern two-thirds of our state is considered rural or frontier. And although that means that population is scarce, it doesn't mean that people aren't sick or dying. It means they are doing so on their own, often without any hospice or palliative care. On February 22nd, I received an email from someone I'll call Jay. Quote, "We found you in a Google search. There's something about your picture that feels like you might be able to help us with my mom's death. My mom has aggressive breast cancer and has been on hospice for 8 days. All is going great. She's saying her goodbyes, and it has been beautiful. Mom has no fear of death, but she does not want to die in pain. Since Oregon made the death with dignity law, she has expressed this would be her desire. We have the prescription, and I will pick it up." We spoke on the phone. Not only did they live 2 hours from the pharmacy for the medications, they lived over 2 hours from me. I offered to connect them with some more local resources. Jay simply replied, "You are wonderful and thank you. I know for certain she wants you. Send me your ideal dates and we will choose." We made a plan for 10 days out. Mom was comfortable now and enjoying time with her family and visiting the school where she had been a teacher for over 40 years. All the students called her Grandma D. However, 2 days later, I got the call. "She's done. Can you be here on Tuesday?" These words signaled for D, as they usually do for the dying patient, that go time is now. So I found myself leaving my house in the dark at 6 a.m. on Tuesday morning, an imminent snowstorm pending in the western skies. I drove the 2.5 hours through rural eastern Oregon to meet them right where they were at, right when they were ready for her to go. I pulled into the driveway at 8:45 a.m. Jay met me at my car, gave me a big bear hug, and said, "I'm so glad you're here. You're exactly who I imagined you would be." I had the gift of spending just 4 hours with them that day, privy to family stories and love and goodbyes. I stayed after Mom completed her life until the funeral home took her into their care. And then I was invited to share a meal. Her granddaughter had arrived shortly after the funeral home. She hadn't wanted to be present during the ingestion. We met in the driveway as sunshine broke through the clouds. Later, over lunch, she would tell me that when she saw me, she felt immediately at ease. My presence felt like an angel was there, and that all would be okay for them. This was the reassurance I needed, that human presence mattered, especially in rural areas. What patients want and deserve is not more information or medicine. What they want and deserve is our human presence. A few days later, I received this closing to an email from Jay. "We are forever grateful for you and how it all went. It felt perfect. It felt like love in motion." I just wanted to share that because I think what it depicts is that the doula role, yes, we can be involved in administering medication. Yes, we can be involved in education for our patients and our clients. But most importantly, what we can be is a calm human presence. And often that is the most important thing that somebody needs, is just somebody to be there to help them feel like it's going to be okay. And with that, I'd like to hand it over. We're going to switch gears into voluntary stopping of eating and drinking, and I'll let Elizabeth take it from here.
Thank you, Erin. And that was the first time I had the privilege to listen to the piece that Erin wrote. So it brought me to tears in a lot of ways. Thank you for sharing that with us. End of life doulas. So I'm just going to give some information about the Vsed process, and then she's going to share as Erin did in some ways, a more illustrative example of what it looks like to work with a Vsed client and their family. And I would say, interestingly, in some ways, the Maid process feels more known and understood by patients and families and providers, right? The Death with Dignity Act passed here in Oregon, where our organization is in 1997. So in some ways, there is a different familiarity. But when considering, priorities around quality of life, symptom burden, and autonomy around an illness trajectory, Vsed, or voluntarily stopping eating and drinking, really has emerged as a topic of increased interest for people who are facing diminishing quality of life. So because there's a confusion around the Vsed, I'm going to go in a little bit more detail, and then Laura and I will have a conversation here. So we have here on the quote or on the screen, a quote from Compassion and Choices related to Vsed. And it says, a person may choose to control their own dying by making a conscious decision to refuse foods and fluids of any kind, including artificial nutrition and or hydration. So Vsed is deemed as a viable option when a mentally capable individual desires to make this decision in order to advance the time of their death. Vsed is legal in all 50 states in the United States and can be undertaken by individuals that have a clearly defined terminal illness that is in some ways associated with a prognosis of months to several years. And the Supreme Court case we have here on the screen, Cruzan versus the director of Missouri Department of Health, in this, the Supreme Court stated a competent person would have and does have a constitutionally protected right to refuse life-saving hydration and nutrition. So this case itself really helps to serve as the legal foundation, or one of the legal foundations for Vsed. Erin, if you can go to the next screen, please. So let's talk a little bit about the timeline. The general range of survival once Vsed has been initiated is 7 to 21 days, and usually is in the range of 10 to 14 days. Having said this, there are definite outliers to this timeline. If someone is navigating an advanced disease process, the time to death may require fewer days overall. Well, for someone who's not navigating, a terminal illness and may have more physical strength going into the Vsed process, the number of days from initiation to death could be longer. So as care providers and end-of-life doulas, I think it's always important and helpful to help to manage expectations around the timelines. With the Vsed client that we supported here in Central Oregon, their death took 7 days, and that unto itself was, a lot of work. So after initiating Vsed, right, it's the dehydration process that fundamentally affects the kidneys and heart, and the other organ systems in the body then begin to shut down. So there's typically 3 phases that someone progresses through with Vsed: the early, middle, and late. So in the early stages of Vsed, the person is generally more oriented, more alert. And it's in this window they may typically be interested in interacting with those around them, right? Caregivers, family members, whoever that kind of ecosystem of care that's in their proximal space. They're likely experiencing occasional hunger pains and maybe thirst and dryness, in the mouth and the throat region. It's likely increasing and becoming more of an issue. The good news is that, in their alertness, they typically know what's going on. So before starting the Vsed process, for doula involvement, it's oftentimes helpful to have a conversation with them, right? Knowing yourself, how might you easily care for, or how would you like to be cared for? What sort of distractions may work better for you? And this can be helpful in both the early and the middle stages when we're supporting someone. So this is the time for connection, sharing, right, being together. And this early stage has a typical duration of 1 to 4 days. But again, there's a lot of outliers to this. And when Laura she'll share some of her story with her client, she'll talk a little bit about where this wasn't actually the case. In this early stage, someone choosing Vsed can also halt the process during these early days when they're still conscious. That's a question that a lot of people have around Vsed. So you can halt it, right, when in these early stages when somebody still has their mental faculties. And if this is desired, the person, it should only be a couple days in. It's always helpful to consult a medical provider just to make sure, right, that the introduction of water and food is done smartly, and just to ensure that the organ systems are still functioning properly. We go into the middle stage, and this is oftentimes, the most difficult for the person choosing Vsed, as well as for their caregivers oftentimes. So kind of with increased dehydration, they'll generally feel weak, fatigued. They can oftentimes suffer from agitation, confusion, sometimes hallucinations. They can begin to sleep for longer periods of time. And then by this stage, it might be this sensation of you've been running a marathon, right? It takes a lot of endurance to follow through with the Vsed process. So due to this, matched with the confusion sourcing from dehydration, this is where the stage where someone may require more frequent reminders about what they're doing, what they're engaged in, and their why. And the duration of this phase is really variable, depends upon a lot of different factors that are particular to the person. And then the third phase is the transition phase, which is signaled by loss of consciousness, organ system failure due to prolonged dehydration. And this is the window where death is near. Typical duration of this phase, 1 to 4 days, and can also be, a lot of variables around that. So next screen, please. So who can opt for Vsed? So Vsed itself is a deliberate self-initiated action, right, by a person to hasten their death. So they must be decisionally capable and have the physical ability to eat and drink and be able to consciously refuse food and fluid in order to advance the time of their death. So for anyone who does not have a 6-month or less prognosis, they themselves cannot qualify for hospice, right? So Vsed may be a compelling option for someone who is faced with unrelieved suffering of a chronic or an incurable or irreversible progressive disorder. So it's somebody assessing their condition and saying, this quality of life is unacceptable to me. And then combining these last 2 points on the screen here, right, for people with degenerative diseases like dementia or ALS or MS, who may not yet be eligible for hospice, right? They don't have a prognosis of 6 months or less, and or they don't qualify for Maid. Vsed can be a viable option to really maintain autonomy at the end of life. Next screen, please. So there's a lot of other factors just to keep in mind around the Vsed process, and I'm going to quickly just run down this list that we have on the screen here. So one, involvement of a supportive medical provider. When you're working with people and or considering this for yourself, it's just really important and smart to involve a healthcare provider who is experienced with Vsed and or is supportive of the Vsed process, right? If this is an issue for someone, there are organizations that can help with locating a doctor. Here in Oregon, End of Life Choices Oregon, in California, End of Life Choices California, End of Life Washington. And that's something that doulas can really be resourced around to say, let me connect you up with these organizations to support with identifying a provider. Engagement with hospice services. So it's really important to get clarification around a local hospice's willingness to enroll someone who wants to pursue Vsed. Most hospices will not provide, as most of us know, right, will not provide direct care to individuals with a prognosis greater than 6 months. However, many hospices will enroll patients after they have started Vsed or when they become unconscious. And because their prognosis is significantly less than 6 months, right, at that stage when they start. Some hospice providers now consider a person eligible for hospice because they intend to Vsed. So it's important to know the supportive stance of health systems and providers can vary greatly. And this is an area that's worth, researching diligently. And right, getting hospice care on board is extremely helpful when it comes to a number of things, including symptom management for somebody. Decision-making capacity. So as I've already said, someone choosing Vsed must have an understanding of their underlying diagnosis and prognosis without Vsed. They also need to be able to clearly understand the Vsed process and, the associated physical and social and emotional challenges by engaging in this process. And they must demonstrate consistency over time, right? In terms of their decision to pursue Vsed. They have to be able to demonstrate this. So when considering when to initiate Vsed, someone really wants to keep their eyes on a number of things, right? How acute is the underlying disease? How much time is required for preparing for Vsed? And, is there a narrowing window of time where the person might have either sufficient or diminishing cognitive capacity to initiate Vsed? So part of the preparatory conversation, as caregivers, as doulas, is about helping an individual and a family kind of ID these markers of capacity and physical ability, so we don't miss this window to follow through with the Vsed process. Documentation of decision making, right? Important to get legal and financial affairs in orders. If there's certain family members that don't feel on board with this decision, might be good to seek legal consultation. Always good to put a statement in your advance directive, right? Declaring your voluntary decision to engage in Vsed, making sure your durable power of attorney for healthcare is supportive and aware of this decision. And then another part of the documentation, oftentimes people will sit down and prepare 2 different videos. The first one being a video that really serves as a means of legally documenting your decision to engage in Vsed. So this is a video of you speaking in real time, or your client speaking in real time, that is demonstrating capacity and sound decision-making related to the process. And then the second video can serve as, a means of kind of a self-reminder and self-advocacy. So reminding yourself why you're doing Vsed, right? What is this about? And this can be a helpful sort of tool to use, right? By day 4 or 5, when maybe somebody has increased confusion due to dehydration, helpful to have this reminder, and seeing yourself on video can help with that. And then caregiving options, right? As I said, Vsed can really be a marathon for people. So, it can be difficult to be a single caregiver with this sole responsibility. So smart to have caregivers in place when possible that can be there with more frequency, ideally 24/7 support if it's available, and know that might be needed over some, a period of weeks. So this could mean engaging family members, friends, those that are kind of part of that inner circle and could be there for support. It could also be a matter of hiring an end-of-life doula or a combination of all of these. And then, knowing it's helpful to pull in caregivers that are not just family, right? Keeping an eye on who gets to be in relationship with that person who's dying, in more of an emotional, familial level. And so more of that caregiving support can be helpful with that. Location, and where to initiate Vsed. A lot of people wish to pursue Vsed in their homes, right? Surrounded by those familiar sights and sounds and personal items and, that place that we love. This also may not be feasible if, caregiving is not available. On the other hand, healthcare facilities or assisted living facilities may have prohibitions against Vsed. So just kind of thinking through these planning elements. And then finally, the process needed to prepare. There's a lot of things people need to do around, colon cleansing, decreasing amount of food and water, 3 to 4 days before, after the cleanse, going to just liquid. So all of these things are, available on a variety of different sites, which we'll show here at the end in terms of some resources. So let's come off the screen here and want to just have a conversation with the lovely Laura Munn, who is here with us, who is a trained, as we said, end-of-life doula. And welcome,
Hi.
Laura. Thanks for joining us here.
Thanks for having me.
And so, Laura, we've kind of talked about some of the main elements of your engagement with this particular family. But for those that are here, I think the first thing just to focus on would be having you tell everybody a little bit more about the client case that you worked with, and how it was that how it came to be that you were pulled in as an end of life doula.
Sure. So I had a family reach out to me via email because they had just searched local doula, local end of life doula in the area, and my number came up. And she reached out to me, and we had a good conversation about what her and her husband's wishes were. And I told her about my limited experience with Vsed and attending people at the end of their life. And she, like Erin said, she just felt like I was the person to be there with them. And so they asked me to help their husband to explore Vsed for hastening his death. He was diagnosed with a frontal temporal dementia and was really determined that he didn't want to be incapacitated and he didn't want to be in a nursing home, that he wanted to die at home peacefully.
Mm. Thank you. Yeah. Did you want to say something else around that?
Well, just when I got drawn in, I felt really like I didn't really know what I was doing, but this woman had really prepared for her husband, and she had done all the research. She's reached out to End of Life Washington. She had all her affairs in order, and it felt like my role there was just to support them in holding the container and being a calm presence for them while they navigated this whole process.
Thank you. That's great. Curious just to hear about some of, what it actually looked like to be involved as a doula, and what in addition to the family doing that kind of preparedness work ahead of you coming on the scene, when it got to the point of actually initiating Vsed, what were some of the steps, or what did it look like for your actual involvement in that case?
Sure. So we had decided that because they had so much family support, they had rented a house in the neighborhood, and they had arranged the care support team to come stay there during the Vsed process. And when he actually started the process, we would have daily morning meetings together with the whole family where we kind of discuss where he's at, how he's feeling, and we would do some yoga and some sound healing to just kind of get everybody kind of recalibrated and back on the same page and in a calm state of being before the day started. And then once it started, they were really adamant about not preparing any food in the home. So they created a meal train that the food was delivered to the rental house. And so some things that were important to them was that there was no food prepared in the home, or sounds of running water, or even sounds of urinating, just to eliminate his desire to eat or drink. And we spent a lot of time together with the family, just kind of talking about desires and needs. And because the client was pretty nonverbal, they had put a lot of things into place, like you suggested, the 5-minute video where he's explaining his desires, and then the 1-minute video where he's explaining to himself what his desires were too. And, he was very physically strong, and he started the process day 1 and didn't ask for food or water the whole time until about day 11. And he went to get a glass of water, and his family was like, "Hey, just want to remind you what you're doing here." And he was confused. But he had been awake and alert and walking and talking and all that stuff the full 11 days when he started the process. And then once he got confused on day 11, they called his best friend from high school, and he FaceTimed with him and just reassured him, "Hey, this is what you're wanting to do. This is your goal." And that night after the phone call, he put the glass of water down and went to bed, and he didn't get up. He fell asleep probably about 12 hours later and didn't wake up.
Yeah.
But there are a lot of sweet things that happened, you know, during that time. Like his family really put together a list of comforting things for him and put it on his door. Things to do with people, things to see, things to touch, and things to hear. And that was really helpful for him for comfort measures. Something that I feel like is really important is to designate a point person, because there can be a lot of different people discussing with hospice and healthcare providers. And so to designate one person who can be in charge of handling all the stuff. And then I'm kind of like the go between. So if something's happening, then I share that with the point person, and then that point person takes it and talks to the healthcare providers.
That's great. And I'm curious, Laura, just, you know, thinking back and, you know, kind of how Erin ended the Maid section with just reflecting on that like lingering lesson or the takeaway. I'm just curious with your engagement with this particular family, a big kind of enduring lesson learned, or just something simple that you take from that experience.
So the biggest things for me was engaging hospice beforehand, and even offering them education, especially if you live in a rural community, because they may not know what Vsed is. So we had to do a lot of education for hospice so that they could, you know, understand what his goals were. And then the other thing was, Erin was my mentor throughout this process. And I said to Erin at one point, you know, I feel like I should be doing something. What should I be doing? And she was like, well, they called you. They want you in your space. All you have to do is be there and support them and be present. And I think you used the word nimble the other day, just like not having any agenda or pushing my views on somebody else, but rather just being really present and taking every moment as it comes and responding in a way that's non-reactive, but just really supportive.
Thank you, Laura. I feel that we've all benefited from just, you know, a combination of both the information and then just as an illustrative example. And what stands out to me is just this piece of, you know, this family was extremely involved, prepared, organized, and yet still benefited from additional support, and in the form of a very grounded, compassionate, loving presence like yourself, right? Which is your ability to kind of hold it from that wider source out, and just to keep your eyes on all these different moving parts, and how essential that was. So thank you for showing up to that family in the way that you did.
Yeah, it was my pleasure. I like the phrase of wrapping around someone, you know, wrapping around them with support and resources and just love and care and companionship. And really, that's all that we desire as humans, you know, is to be held when we're suffering.
Absolutely. Thank you.
But I just want to thank everybody once again for joining us. We're really grateful for your interest in not only these end-of-life options, but the doula role in these options. And please reach out to us if there's anything that we can be supportive with. I didn't make a slide with our website unless it's on this previous slide, but it's not. The peacefulpresenceproject.org is our website, and you'll have that in the follow-up email as well. But please reach out to us if you have other questions or needs for resources. And thank you, and have a really great night.